I'll teach gynecology for. So LI. So let's see. We were doing Tanner staging. So Tanner staging is a very important question. So stage 1 to 5 is there. Stage 1 in breast is pre-pubertal stage. There is elevation of papilla only. Then breast buds and papilla will be slightly elevated, and the site of labia areola will begin to enlarge around 10 years. Further enlargement of entire breast tissue will occur. Then there is secondary mold of areola and papilla projecting above the breast tissue, occurs around 12 years. Finally, you have the area which recedes to the general contour of the breast around 15 years. And then pubic hair, first stage you'll have no pubic hair will be present. Second stage you'll have sparse long hair on either side of the majora around 10 years. And third stage you'll have darker, coarser and curly hair. Then fourth stage is adult type hair covering the mons only. And finally you have adult hair with inverse triangle distribution covering the medial thighs also. Okay, so first you have no, then you have sparse long hair on either side of the majora, then you have darker, coarser and curly hair on over the mons pubis, then you have adult hair covering only the mons, then you have inverse triangle distribution covering the medial thighs. Then we speak about precocious puberty, which in female is the onset of menstruation with the age of 10 years. Within the age of 10 years, and there is appearance of breast budding within the age of 8 years. Males, there is onset of puberty within the age of 9 years, and GnRH dependent. There are two types of precocious puberty. There is GnRH dependent and there is GnRH independent. GnRH dependent is central precocious puberty, and GnRH independent is peripheral precocious puberty. Then causes of precocious puberty, you have constitutional or idiopathic, and you have specific etiology. So constitutional or idiopathic is no known causes there. It is 80% of the cases. And specific etiology, you may be because of hydrocephalus. It may be because of astrocytoma, glioblastoma, neurofibroma, and ependymoma, pineal and arachnoid cyst, and hematoma. Acquired lesions, it can be due to trauma or head injury, inflammation, meningitis, encephalitis, rickets, hypothyroidism, and von Ruxham's. Oh my god. Okay. Okay, so it can be von Ruckling-Hansen's disease. So causes of peripheral precocious puberty, wherein the hypothalamic pituitary ovarian axis is intact. So you have isosexual and heterosexual. Isosexual ovarian causes will be there due to granulosa cell tumor, theca cell tumor. Hydrocephalus, trauma, peripheral precocious tumor. Okay. Then adrenal causes, feminizing adrenal neoplasia, general adrenal causes, dysgerminoma, choriocarcinoma, hepatoblastoma, exogenous secretion of estrogen in the form of oral contraceptive pills, corticosteroid intake, McCone-Albert syndrome. Heterosexual is convergent adrenal hyperplasia, congenital adrenal hyperplasia, then ovarian aldosterone secreting tumors, and exogenous androgen. All of them will cause peripheral precocious puberty. So clinical features, you will have premature growth spurt, premature theology, puberty, and menarche before 8 years. And this is cyclical vaginal bleeding without any secondary sexual characters. Then investigations, you will have X-ray, hand and wrist will be non-dominant. There is acceleration of growth. Then pelvic sonography, you will have a rule out. You have to do to rule out Ovarian pathology, skull X-ray, CT scan or MRI brain will rule out the intracranial lesion. Serum HCG, FSH and LH, thyroid profile, TSH and T4, serum estradiol, testosterone, 17-hydroxyprogesterone, dihydroepiandrosterone, DHEA. All of them should be done, and electroencephalogram can also be done. Treatment is GnRH agonist. Method of action is to suppress the premature activation of hypothalamus pituitary axis by receptor down regulation. So it suppresses FSH-LH secretion, it reverses the ovarian cycle, it establishes the amenorrhea, and it regresses the breast and pubic hair. Dosage is buserelin, which is nasal spray, 100 mg daily. Then you have medroxyprogesterone acetate, 30 mg daily orally. So it suppresses the gonadal steroids, it suppresses menstruation, suppresses the breast development, and you cannot change the skeletal growth rate. Then you have ciproterone acetate, medroxyprogesterone acetate, ciproterone acetate. It is a agonist effect on progesterone receptors. Then dosage is this much for 10 days from 5th day of the cycle. Then you have danazole, which produces amenorrhea and arrests the breast development. Danazole produces amenorrhea and arrests the development. Medroxyprogesterone acetate suppresses gonadal steroids. Menstruation also will suppresses the breast development, and cannot change the skeletal growth rate though. But main is GnRH analog, buserelin. This is from Dragon Ball, this is from Apple, and this is from Full Metal Alchemist Brotherhood. Then we have delayed puberty, which is no breast development by age of 14, no menarche by age of 16, caused due to hypergonadotropic hypogonadism. Due to gonadal dysgenesis, pure gonadal dysgenesis may be there, and ovarian failure will be there. Then hypogonadotropic hypogonadism is a constitutional delay, chronic mental illness, malnutrition, and primary hypothyroidism, isolated gonadotropin deficiency, which is Kallman's syndrome, which is isolated gonadotropin deficiency. And intracranial lesion, you will have craniopharyngioma and pituitary adenomas. Eugonadism, you have anatomical causes, which is Mullerian agenesis, imperforate IL-1, and transverse vaginal septum. Then androgen sensitivity syndrome also, insensitivity syndrome also may lead to delayed puberty. Mullerian agenesis, imperforate hymen, transverse vaginal septum, hypergonadotropic gonadotropism, which is Kallman's syndrome, primary hypothyroidism, chronic illness, malnutrition, constitutional delay, intracranial lesion, which is craniopharyngioma, pituitary adenomas, and hypergonadotropic hypogonadism is gonadal dysgenesis, pure gonadal or ovarian failure. Okay. So puberty menorrhagia, which is excessive cyclical regular bleeding occurring in adolescence, caused due to dysfunctional uterine bleeding, and ovulatory cycles will be there, unopposed estrogen will be there, endometrial hyperplasia and heavy periods will be there. Then you have endocrine dysfunction, which is polycystic ovary syndrome, and hypo or hyperthyroidism. Then you have hematological, which is idiopathic thrombocytopenic purpura, von Willebrand's disease, and leukemia. Then you have pelvic tumors, fibroid uterus, sarcoma botryoides, and estrogen producing ovarian tumor. All of them are pelvic tumor. So management protocol of puberty menorrhagia is rest assurance and hemodynamics. If it still continues, we aim for the investigations. Hemoglobin percentage, peripheral blood smear, platelet count, clotting factors, ultrasound, thyroid profile, blood transfusion if it is required. Then mainly it will be primary dysmenorrhea, like DUB. Wait 1 second. I forget what they call it. Dysmenorrhea? I don't know. They call it DUB, but it's dysmenorrheic uterine bleeding, something like that. Okay, so majority of okay, look, it will be dysfunctional uterine bleeding. Sorry, my bad. Dysfunctional uterine bleeding. It will be causes anovulator cycle, unopposed estrogen, endometrial hyperplasia will lead to heavy bleeding. Endocrine dysfunction will lead to polycystic ovary syndrome and hypo and hyperthyroidism. And hematological, you'll have idiopathic thrombocytopenic purpura or von Willebrand's disease and leukemia. Pelvic tumors, you have uterine fibroid of the uterus, sarcomata by portioids, and estrogen placing tumor. Then you have aim for investigations you do. So you'll have primary dysfunctional uterine bleeding, which is progestin therapy should be given. Medroxyprogesterone acetate 10 to 20 mg daily should be given. If it is responsive, then you continue the cycle for 2 to 3 cycles. Then if it's not responsive, then you give conjugate estrogen 20 to 40 mg IV every 6 to 8 hours. If that is responsive, then you combine it with oral contraceptive pills containing 50 microgram of estrogen. Then if it is not responsive, then you give exploratory EUA DNC. And you do biopsy. Basically, it is EUA is basically inspection or just opening and seeing if there is any lesion in the uterus. Then it can be secondary due to thyroid dysfunction, ITP, idiopathic thrombocytic purpura, leukemia, von Willebrand's disease, anatomical disorders, and pregnancy complication. You have to give appropriate therapy for them. Okay, so menopause and related problem. Menopause is permanent cessation of menses after last menstrual period followed by 12 months of amenorrhea. Okay, menopause is permanent cessation of menses after last menstruation period followed by 12 months of amenorrhea. Okay, climatic. It may be passes from reproductive to non-reproductive stage. It is called climacteric. It covers 5 to 10 years on either side of the menopause. Okay, perimenopause is period around menopause, 2 to 8 years preceding and 1 year after menses, characterized by fluctuating hormone levels, irregular menstrual cycle, and menstrual symptoms. Okay, then we move on to post-menstrual bleeding. So, bleeding per vagina in an established menopause or normal menstruation continues even beyond 55 years of age. So, only the first definition is correct. I feel the second one I doubt it's post-menstrual bleeding. Then causes. Causes may be exogenous estrogen, HRT, vaginitis, trabecular candida, chlamydia, senile vaginitis, all of them can occur. Endometrial hyperplasia, cervical carcinoma, uterine sarcoma, dysfunctional uterine bleeding, anovulatory ulcer or foreign body. Bleeding from vagina, bladder, rectum, which is mistaken from as bleeding from vagina. Then endometritis, which is trabecular, senile, polymetra and hematometra. Endometritis may be there. Endometrial cervical polyp, endometrial cancer, ovarian cancer, fallopian tube carcinoma, and injuries, which is direct or decubitus ulcer. So it can be exogenous HRT, vaginitis, endometritis, endometrial polyp, endometrial carcinoma, ovarian carcinoma, fallopian tube carcinoma, trauma, cervical carcinoma, uterine sarcoma. Uterine sarcoma, and DUB, ovulatory ulcer, foreign body. Okay, so management, speculum examination. So visible cervical growth means you do a biopsy. If there is cervical growth, you do the biopsy of the cervical growth. Carcinoma apparently looking normal. Cervical and endocervical smear you have to do. Aspiration cytology will lead to endometrial carcinoma. People endometrial sampling should be done. Then bimanual examination can be done. Ultrasonography, transvaginal you have to do. Saline infused sonography, SIS, can be done. Hysteroscopic evaluation and directed biopsy can be done. Endometrial biopsy can be done. Fractional curettage, laparoscopy followed by ovarian or adnexal mass, CT and MRI can be done. Laparoscopy, CT, MRI, fractional curettage, endometrial biopsy, saline infused sonography, hysteroscopic evaluation, sonography, bimanual and speculum examination. Okay. Treatment is recurrent or continuous bleeding. You do laparotomy to perform hysterectomy with bilateral self-oophorectomy. I mean, it's already old patient, you can just remove it. Then artificial menopause is permanent cessation of ovarian function done by artificial means due to surgical removal of ovaries or by radiation. Okay. Menopausal symptoms. So menopause is a cessation of menses by last menstrual period followed by 12 months of amenorrhea. Perimenopause is time surrounding menopause, 8 years before and 1 year after LMP. Then diagnostic criteria of menopause is cessation of menopause, appearance of menopausal symptoms, hot flushes, vaginal cytology you have to do 100 then serum estradiol will be very much less, serum FSH and NLS will be very increased. So hot flushes, first of all, give me a second. Important symptoms are, first you have vasomotor symptoms, which is hot flushes. There will be recurrent periods of flushing, sweating, sensation of heat accompanied by palpitations. Then it will be caused due to estrogen withdrawal, coincides with LH surge. So it coincides with LH surge. Each episode 1 to 3 minutes, recurs 50 to 10 times in a day. So treatment is combined estrogen and progesterone therapy if uterus is intact, estrogen in a hysterectomy patient, and tibolone, which is steer selective estrogen activity regulator, tibolone. So because hot flushes, because of recurrent flushing, sweating and sensation of heat accompanied by palpitation, you can treat it with estrogen and progesterone therapy if uterus is still intact. Only estrogen if hysterectomy is done. Tibolone, which is selective tissue and estrogen activity regulator. Then urogenital atrophy. This is the atropic changes. Urogenital atrophy is the atropic changes in urogenital epithelium due to estrogen deficiency. It can be dyspareunia or it can be dysuria. Uterine atrophy will be there. Dyspareunia and dysuria. Painful during sexual intercourse or painful while urinating. Then osteoporosis and fracture, decline in collagen bone matrix, resulting in increased risk of fracture. Treatment is combined estrogen and progesterone therapy if uterus is intact. Then you can have estrogen, which is hysterectomy patient, tibolone, which is steer selective tissue estrogen activity regulator, raloxifene, which is selective estrogen receptor mediator, something like that. Yeah, selective estrogen receptor mediator, bisphosphones, and calcium and vitamin D can be given for osteoporosis and fracture. Bisphosphonates. Okay. Combined estrogen and progesterone therapy. Then cardiovascular disease or cerebrovascular disease, you have oxidation of LDL leading to vascular endothelial injury, leading to vascular atherosclerotic and thrombus formation. Psychological changes, you have anxiety, headache, insomnia, irritability, dysphagia, depression, dementia, and mood swings. All of them can be there. Lot of problems will be there. Skin and hair, there will be loss of elasticity and wrinkling of the skin. Sexual dysfunction, estrogen deficiency. Estrogen deficiency will lead to decreased sexual desire. Then senile vaginitis, you will have dry vagina due to decreased estrogen. Treatment is by topical estrogen application. You apply estrogen topically. Then we move on to menopause, ovarian failure leading to depletion of ovarian follicle, leading to anovulation and decreased estrogen production by ovary. Anovulation will lead to infertility and there is decreased progesterone and amenorrhea. Then estrogen production by ovary will be decreased, so it will lead to senile vaginitis. Okay, it will lead to estradiol production decreases, estrogen formation by conversion of androgen remains more or less normal. Main estrogen is estrone. Overall level of estrogen will decrease. So there is a decreased bone mass and osteoporosis. Then you have negative feedback on FSH is lost. Therefore, increase in FSH is more than 40 international units on 2 occasions 1 month apart. Then FSH is excreted in urine of postmenopausal female and is basis for obtaining HMG human postmenopausal gonadotropin. Instead of HCG, it's HMG, human postmenopausal gonadotropin. Urogenital osteoporosis and fracture, cardiovascular oxidation of LDL, vascular injury, vascular atherosclerosis and thromboformation, anxiety attack and stuff like that, loss of elasticity and wrinkling of skin, estrogen deficiency due to sexual dysfunction, and senile vaginitis. Non-hormonal treatment of menopausal symptoms. You have weight management, adequate calcium intake, vitamin D supplementation, cessation of smoking and alcohol, and drugs. So, non-hormonal management: weight you have to manage, adequate calcium you have to have, vitamin D you have to supplement, you have to stop smoking and alcohol, and you have to take some drugs. Bisphosphonates, which prevent osteoclastic activity, bone reduction, improves bone density, and but it may lead to esophageal ulceration, osteomyelitis, jaw osteonecrosis. Fluoride can be provided, which prevents osteoporosis and increases the bone matrix. Selective SERMs, estrogen receptor modulators, raloxifene. Very much important. They increase the bone mineral density, reduce serum LDH, raise HDL. It does not prevent hot flushes or urogenital atrophy, however. Then you have clonidine or paroxetine or gabapentin, which reduces severity and duration of hot flush. Clonidine, paroxetine is antidepressant. Soy protein acts as a SERM and it reduces vasomotor symptoms. Soy protein. Then HRT for menopausal symptoms. So indication: if relief is required, osteoporosis, maintain the quality of life, premature ovarian failure if it is in cases of premature ovarian failure, gonadal dysgenesis also you have to provide HRT, surgical or radiation menopause you have to provide HRT. So benefits are decrease vasomotor symptoms, decrease atropic urogenital atrophy, increase in bone mineral density, decrease risk in vertebral and hip fracture, and reduction in colorectal cancer. So its effect can be thromboembolic events. Use of estrogen progesterone not with estrogen alone. Breast carcinoma will be the side effect with estrogen and progesterone not on with estrogen alone. Ovarian cancer with estrogen and progesterone. Endometrial cancer, which is seen in use of estrogen alone. So estrogen alone will increase endometrial carcinoma. Dementia may be seen, coronary heart disease will be there, stroke will be there, cholecystitis will be there. Contraindications: you have acute liver disease, undiagnosed vaginal bleeding, cancer of the breast or uterine, and deep vein thrombosis. All of these are contraindication. Liver, breast or uterine cancer, undiagnosed vaginal bleeding, DVT. All of them are not recommended for HRT. Okay, again. Talking about side effects again, we'll have first you have thromboembolic events with estrogen and progesterone, not with estrogen alone. You have breast cancer with estrogen and progesterone alone, not with the estrogen alone. Ovarian cancer with estrogen and progesterone. Endometrial cancer with only estrogen. Dementia. Endometrial cancer with only estrogen. Ovarian cancer with estrogen progesterone. Breast cancer with estrogen progesterone. Thromboembolic disease with estrogen progesterone. Dementia will be there. Coronary heart disease, stroke, and cholecystitis. Okay, just 1 second. Then HRT preparation is estrogen, which is ideal in hysterectomy patient. Intact uterus, estrogen therapy, endometrial hyperplasia, and carcinoma will occur. Okay, in hysterectomy patient only estrogen can be provided. Estrogen and progesterone therapy in ideally in intact uterus. So you have conjugate estrogen and micronized estrogen. Progesterones, you have medroxyprogesterone acetate, micronized progesterone, and dydrogesterone. Okay, 2.525, 6.625 to 1.25. A fifth of medroxyprogesterone acetate, 1:5 ratio. Dydrogesterone is times 2 is dydrogesterone, 5 to 10. Mode of therapy, you can do subdermal implants, percutaneous estrogen gel, transdermal patch, and vaginal cream. Give me a second, one second. Okay, so premature ovarian insufficiency, which is ovarian failure, occurs before the age of 40, caused due to intrauterine life, failure of germ cell maturation, and accelerated rate of germ cell depletion, which is apoptosis. This is premature ovarian insufficiency. Its causes can be idiopathic, it can be genetic. Turner syndrome, gonadal dysgenesis, trisomy, and X chromosome deletion and translocation. It can also be anti-nuclear antibody. APLA syndrome. Wait, no, not APLA. Anti-nuclear antibody. SLE, lupus anticoagulant, and polyglandular autoimmune syndrome. Then infections may be mumps and tuberculosis. Iatrogenic, it can be radiation, chemotherapy, and surgery. Metabolic, you will have galactosemia. Follicles will be destroyed by the effect of galactose. Alpha hydroxylase deficiency is another important reason. Then investigation, C2 history of amenorrhea, less than 35 years old. FSH will be very much increased, similar to menopause levels. Serum estrogen less than 20 picogram, exactly similar to menopause. Same as menopause. Then ovarian biopsy will be there, where you'll find a follicular, and autoimmune variety will be there. So management is to minimize the post-menstrual hazard by providing HRT. Like post-menopausal health hazards should be minimized by HRT. Autoimmune disorders, you can give corticosteroids, and gonadotropins you can provide for ovarian induction. IVF you can do, in vitro fertilization with donor oocyte with total replacement of hormones. Okay. Then pyometra, this is a collection of pus in the uterine cavity caused due to carcinoma endometrium, senile endometritis, tubercular endometritis, congenital atresia of vagina cervix, stenosis of cervix or vagina, following which you do surgery, burns, and radiotherapy. Like after surgery, burns, and radiotherapy, you have stenosis of carcinoma of vagina, carcinoma of the cervix, and carcinoma of the corporis. Now, pathologically, cervical carcinoma is narrowed due to senile narrowing by fibrosis or due to debris. So, there is secretion of pus from etiological sites. There is accumulated pus distending the uterine cavity, and uterus gets enlarged. There is thinning of uterine wall. Senile endometritis, carcinoma endometrium, trabecular endometritis. Atresia of the stenosis, corporis. Clinical features, you'll have intermittent, blood-stained, purulent, offensive discharge per vagina. There is pain in the lower abdomen, and you have suprapubic swelling. Diagnosis is by pelvic ultrasonography. There will be distended uterine cavity with accumulation of fluid. Then treatment, you have pyometra is drained by simple dilatation of cervix and hysterectomy. That is the treatment. You remove the uterus and you can drain it with simple dilatation of cervix. Then breast and gynecologist, you have gyrectoria, which is secretion of a milky white fluid, which is inappropriate, unrelated to the childbirth. Okay. Pathophysiologically, it is caused due to hyperprolactinemia, which inhibits GnRH pulse secretion. Gonadotropin will be suppressed, inhibits ovarian steatogenesis, hypogonadotropic hypogonadism. You will have amenorrhea, and anovulation. And first main important thing, you will have galactorrhea, hyperprolactinemia. So treatment is bromocriptine and carbidoline, which increases GnRH production. Something like that you can see. Bromocriptine is dopamine agonist. Okay. Bromocriptine, carbogylline. I think they're just GnRH agonist. Whereas here, where is this? In post-menstruation, like postmenopausal, to decrease the side effects, you provide, right, FSN, 40 ml in international units, less than 20 picogram, hot flushes. Okay. Yeah. Okay. Buserifone. Where is buserifone? Where does it provide? I forget. Just 1 second. Precocious puberty. In precocious puberty, to delay the puberty, they give buserine, which is GnRH agonist. Buserine is GnRH agonist. So whatever I was thinking is wrong. It's not GnRH agonist that you provide. Bromocriptine is probably just dopamine. This logic is completely flawed. 1 second. Okay, bromocriptine is used for it's an anticholinergic, and it is used for suppressing the progesterone. Okay, there's nothing special about it, to be honest. Okay, mastalgia is painful breast. It can be cyclical, seen in young women few days before menstruation and during luteal phase of around bilateral and diffuse with her most severe during luteal phase of menstruation. Then you have cyclical, which is mostly seen in older women, may be a symptom of breast carcinoma, cyst, Tay syndrome, which is chest wall pain. It has no relation to menstrual cycle. It is often focal. Then treatment of mastalgia, you have cyclical and non-cyclical. Cyclical, you examine, you have Tay syndrome and NSAIDs and anesthetics, steroid injection in case of non-cyclical to rule out cancer, and investigation for cyclical. If it is cancerous, then you treat it. Then for treatment of mastalgia, cyclical, you do examination. Mild requires assurance and observation. Moderate requires only treatment. Okay. Cyclical is okay. Non-cyclical, you treat, and if it's Tay-Sachs, you give NSAIDs and steroid injection. Okay, moderate, analgesics can be provided, or vitamin B6 100 mg daily, or evening primrose oil you can do. If there is no improvement, you can give danazole and bromocriptine, which is again against prolactin. If there is no response, or if there is severe mastalgia, you can give GnRH analog, buserelin and testosterone, goserelin maybe. Okay, testosterone can be provided, tamoxifen. Wait, just 1 second. I'll have to tamoxifen. I suddenly am not remembering. I remember it's anti-estrogen drug, but I don't know. For some reason I'm blanking out where I read it. Wait, it's a SERM, right? Relaxation, tamoxifen. Yes. Then fibrocystic breast disease, which is due to altered estrogen progesterone ratio. Then it is related to decrease in progesterone, stress and nulliparity, and delayed menopause. And more amount of estrogen than it is causing fibrocystic mass characterized by adenosis, fibrosis, ductal epithelial proliferation, and papillomatosis. There are two types of observed. You have local and you have diffuse. So clinical feature: breast discomfort may be accompanied by a palpable mass. Cyclical premenstrual mastalgia may be seen. So you'll have bilateral involvement and palpation, older nodular area of ill-defined lumps, which is prominent in premenstrual phase. Treatment is acetaminophen or NSAIDs and reduction of intake of methyl xanthines like coffee, tea, caffeinated soda, and tobacco. Decrease methyl xanthines. Then vitamin E you can give 400 mg daily. Cyclical combine the estrogen progesterone preparations can be given. Danazole can be provided 100 mg daily. Bromocriptine 2.5 to 5 mg daily at bedtime. Then sexual development and developmental disorders. We have Turner syndrome, which is 45X, which is gonadal dysgenesis or monosomy X. Most often is a result of loss of parental X chromosome. Clinical features: you have absence of secondary sexual characters, short stature will be there, streak gonads will be there, primary amenorrhea or primary infertility will be there. They'll have a broad chest, there will be neck webbing, urinal tract anomalies will be there, bicuspid valve, aortic valve will be there, and normal intelligence will be there. So investigations, you will have a sex chromatin study will be negative. Karyotype is 45XO, serum E2 is very low, serum FSH and LH will be elevated, and obstetric ultrasound will have nuchal skin fold thickening and cystic hygroma will be there. This is the Turner syndrome. Cystic hygroma, nuchal skin fold thickening, karyotype will be 45XO, sex chromatin study will be negative, serum estrogen will be very much low, FHL and LH will be very much increased. So they will be having absence of secondary sexual character, normal intelligence. Okay, they will be having normal intelligence. Bicuspid aortic valve and aortic oscitation is common. Urinary tract anomalies will be there. Neck will be webbing. Broad chest will be there. Primary amenorrhea, primary infertility will be there. Short stature and streak gonads. Then we have Klinefelter syndrome. It is meiotic, non-disjunction of sex chromosome during gametogenesis. So patients are infertile but not important. They have a function of penis or vagina. Then most common cause is primary testicular failure. Males with Klinefelter syndrome, there will be damage to both seminiferous and Leydig cells will occur. Testis will be small and firm. Seminiferum, it will be functionless. Cryptorchidism and sterility will be there. Testosterone will be decreased, leading to oligospermia, azoospermia. Males are under virilized or externally genital hypoplasic. Negative feedback on LH and FSH will be lost. So LH will increase, they will stimulate Leydig cells. Aldosterone will be produced raised peripherally, it is converted to estrogen. Gynecomastia will occur and length of arms and legs will be increased. So FSH and LH will be very much increased. Leydig cell will still be working. Androstenedione will be producing estrogen, which will lead to gynecomastia and lengthening of arms and legs. Then increased risk of SLE, there will be increased risk. Breast carcinoma, increased risk. Diabetes mellitus and intellectual defects, there will be more risk. So diagnosis, you can do testicular biopsy. You'll have hyalinized seminiferous tubule, Leydig cell of hyperplasia. And FSH and LH will be raised, testosterone will be reduced. Management is by testosterone therapy. Then congenital adrenal hyperplasia is an autosomal recessive disorder causing enzyme deficiency. 71 hydroxylase, 11 hydroxylase, 78 hydroxylase. Hydroxylase 11, 17, 21. Adrenal hyperplasia. It is the most common causes of ambiguous genitalia in female. These three are the hormones. One second. Before I continue, how much is there? So generally, abnormal uterine bleeding I have to do. Primary, secondary amenorrhea, yes. Latent fibroid endometriosis, hormonal therapy in gynecology, yes. Infertility and sterility is very much important. Birth control mechanism, yes. Medical to MTP, genital prolapse, yes. Displacements, I have to do benign disease of the ovary, benign disease of the vulva, benign disease of the vagina. These three are okay. Pelvic inflammatory disease is very much important. STDs including HIV infection, urinary tract infection diseases. Yeah. Genuinely, I have to do all of this. So, somewhere over here, all this has been done. Ideally, I finish up to here and I sleep because carcinoma, cervix and all are very much easy, and they'll just take 1 hour to do. So another 3 hours of work is there. This is hirsutism, congenital hyperplasia, and this leads to hirsutism. Fine. This entire flowchart is not that important. You can just write a few words like cholesterol to 17 hydroxypregnolone will be formed by 17 hydroxylase. Progesterone to deoxycortisone and aldosterone will be produced by 11 hydroxylase. If there is in deficiency of them, it will lead to decreased androgen production. So you will have androgen deficiency. Okay, salt wasting will be there, hypotension will be there, and androgen excess may be there, which will lead to ambiguous female genitalia and male precocious puberty. First of all, you'll have androgen deficiency. Aldosterone deficiency, and you'll have androgen excess. Testosterone and all will be excess, leading to ambiguous female genitalia and male precocious puberty. Aldosterone deficiency, salt wasting, and hypotension. Salt wasting, hypotension. Okay, 11 hydroxylase is D. 11 hydroxylase is here. So cortisol to 17 hydroxypregnolone, all of them will not be formed. Here also it's 17 hydroxyprogesterone or pregnolone will not be formed. So there will be androgen. Okay, look, dehydro. 11 hydroxylase deficiency, if it is there, 11 hydroxylase will lead to deoxycortisone excess. It will lead to mineralocorticoid effect. Salt and water retention will be there, and hypertension will be there. Completely opposite of this. Okay, then androgen will be excess, leading to ambiguous female genitalia and male precocious puberty. Then 17 hydroxylase aldosterone excess will be there, which is salt water retention, yeah, and hypertension. Okay, aldosterone excess will be there, but androgen deficiency will be there. Delayed sexual characters in female. And male, it will be ambiguous genitalia. Male ambiguous genitalia will be there. Then treatment is drug of choice is dexamethasone, which reduces excessive ACTH secretion. Just provide dexamethasone. Okay, it leads to hirsutism because hirsutism will occur. Then hirsutism is polycystic causes of hirsutism. You have ovarian causes, adrenal causes, obesity, android causes, exogenous drug therapy, postmenopausal, pituitary tumor, and idiopathic. Ovarian, you have PCOS, and you have Sertoli Leydig cell tumor, and Hilus cell tumor, lipoid cell tumor, hypertrichosis leading to leutoma of pregnancy. Adrenal, you will have Cushing syndrome, and you will have adrenal tumor. Obesity of the android variety, you will have insulin resistance and androgen excess, and hair and syndrome. Exogenous drug therapy, you will have androgens, anabolics, oral contraceptives, synthetic progesterones, and danazol, phenytoin, diaxolone, diazolide, cortisone, etc. Okay, postmenopausal also can give pituitary secreting tumor, you have excessive ACTH, excessive growth hormone, Cushing syndrome, acromegaly can be found. Then you have idiopathic due to increased sensitivity to androgens. Common disorders of menstruation, you will have metrorrhagia, which is irregular acyclical bleeding from the uterus. Causes of acyclical bleeding, you have dysfunctional uterine bleeding, submucous fibroid, uterine polyp, carcinoma of the cervix, and endometrial carcinoma. Then causes of contact bleeding, you have carcinoma of the cervix, mucus plug of the cervix, infections you will have chlamydial or trabecular cervicitis, and cervical endometriosis. Okay. Causes of intramenstrual bleeding, you have urethral caruncle, ovarian bleeding, breakthrough bleeding in pelvis, and IUCD in uterus, and decubitus ulcer. Those are intermenstrual bleeding. We are basically listing possible causes of dysmenorrhea, increased reading, irregular acyclical bleeding from uterus. Okay, it may be DUB, dysfunctional uterine bleeding, submucous fibroid, uterine polyp, carcinoma cervix, contact bleeding like carcinoma of the cervix, mucous polyp of cervix, infections which like chlamydia or trabecular cervicitis, cervical endometriosis. Causes of intermenstrual bleeding, you'll have urethral caruncle, ovular bleeding, breakthrough bleeding in pelvis, IUCD in utero, and decubitus ulcer. Treatment is directed to the underlying pathology, malignancy to be excluded as per any definitive treatment. Dysmenorrhea is painful menstruation disturbing daily activity. So it can be primary or spasmodic type, or it can be secondary or congestive type. In primary and or spasmodic type, there is no underlying pelvic pathology. In secondary, there is underlying pathology. That's the only difference. Okay. Pain is seen in ovulation cycle, less than 1 year of menarche. Pain appears on first day of menstrual period. It never persists beyond 48 hours. It is spasmodic type of pain. Pain starts in the lower abdomen. It can radiate to the back and medial aspect of thigh, and condition disappears following childbirth. So treatment is prostaglandin synthesis inhibitor, which is mefenamic acid, oral contraceptive pills, which makes the cycle anovulated. Okay. Surgery is dilatation of the cervical canal, paracervical block, parasacral neurectomy, and uterosacral nerve ablation. Luna. Secondary congestive is pain due to pelvic pathology. Pain seen many years after menarche, seen in anovulatory cycles too. Deep-seated pelvic pain without radiation. appears 3 to 5 days prior to menses and relieved with the start of menses. Important causes of pelvic inflammatory disease: endometriosis, adenomyosis, UCD in utero, uterine fibroid polyps, cervical stenosis, bicornuate uterus. Management is treatment of underlying cause. Then you have metal strains or ovular pain, which is history of sharp pain in the lower abdomen every month, 2 weeks before menstruation, suggesting menstrual, associated with rupture of ovarian follicle at the time of ovulation. Characteristically, it appears in mid-menstrual period. A pain is usually situated in the hypogastrium or to one iliac fossa. And pain is usually localized on one side and does not change side according to which ovary is ovulating. Nausea and vomiting is conspicuously absent. It subsides within 12 hours, associated with slight vaginal bleeding or mucoid discharge. The probable factors are increased tension of graphene follicle just prior to rupture, peritoneal irritation by follicular fluid following ovulation, and contraction of tubes and uterus. Management is by assurance and analgesic. In refractory cases, cycles are made anovulatory by administering oral contraceptive pills. Abnormal uterine bleeding, menorrhagia, cyclical bleeding at normal intervals. Bleeding is either excessive in amount, more than 80 ml, or duration, more than 7 days, or both. Menotaxis is prolonged bleeding. Give me a second. Actually, I'll start abnormal uterine bleeding and I'll finish it off after some time. Actually, I'm genuinely tired right now.